obesity is actually has been a very much an impediment to any kind of procedure. Should we wait a little bit more? Don't worry.
We'll see.
Okay, well, thank you very much. High BMI is a big deal, and it's an epidemic in the United States, but as well around the world. Now, when we talk about the high BMI, like this patient, who is literally 500 pounds, our societies say if somebody's BMI is above 40, do not do elective surgery for a good reason, because the risk versus benefit is not justified. Literally what we do as surgeon, risk versus benefit. And based on lots of data we have, we know that traditional surgery is not a good option for a patient with BMI above 40. Our solution for this patient is most of the time go lose weight. And I just want to emphasize, for a patient who is like a BMI of above 40, the first action should not be surgery. As a matter of fact, for no patient, first action should be surgery. Now, this patient had a laminectomy, was 350 pounds, but that patient had post-laminectomy syndrome, more listhesis, more stenosis, and a group of surgeons got together and told this patient, you do need a surgery, but you have to go and lose 100 pounds and come back for surgery. Now, he went and he gained 100 pounds, has been non-ambulatory for 6 months. By the time, and you know what happens when people are non-ambulatory, their cardiovascular system shut down. And our solution is always not in my service, because we don't want to own the complications which arise from this kind of surgery. This patient, they don't go live with the pain. They go shut down, their cardiovascular system shut down. They go and have a cardiovascular event and die, but it's just not on our book. Now, this patient is come from Cleveland. After Cleveland Clinic tell the patient, you cannot have a surgery for a good reason. These are good surgeons. They know that the risk versus benefit is not justified. This is how he looked like on the table. Now the question is here not, should this patient should lose weight? Absolutely. The question is not, should we do surgery on this patient or not? Risk versus benefit in your hand. But the question is there an option? Is there even an option for a patient like this? And I hope I can answer that question for you with a yes. That there is an option, that this patient, they don't need to gather their pills to commit suicide, because that is where these people are. Life has no meaning to them anymore. They are in pain, and they are told, just go lose weight, and some do, but some cannot. Now the question is, this is the pathology of this patient. Nobody doubts that this patient needs help. You're just unable to provide that. Now, this is another patient. This is a patient with a BMI of 52. By the way, this patient BMI is 62.5. This patient is BMI 52. This is a 40-minute procedure, and you see ischemic area in the belly. Now, let's go on. This patient, as well BMI 55, after 52-minute procedure, you see how the entire upper region is cyanotic. Now, I hope this alone tells you why we cannot do an 8-hour surgery on this patient. Now, the patient that you saw with the BMI of 62.5, we come back to that. We had difficulty to revive his lungs after a 1 hour and 50-minute procedure. Now, imagine you go like that for 8-hour surgery. So those doctors who told this patient, you cannot have the surgery, they weren't wrong. But they only were wrong about that there is another method, there's another way of helping this patient that doesn't require them to be under anesthesia for 8 hours. Now, let's talk about that a little. Obesity is a problem that is not going to get better. Everybody talk about all these fantastic ways of reviving our connection to the nature, walking and so on. The fact is that it's just getting worse and worse, and we have to deal with this patient somehow. And I need you to understand, generally MIS is not about what happens in the skin level. It's what happens under the skin. And all the tissue you don't have to destroy, it makes it MIS. Now, and that is the whole thing. If you can be reducing the damage to the tissue and be more efficient. Now, there are very few surgeons like Dr. Snokrobi who are very efficient no matter what they do. It is not unusual that some of our colleagues, they say it's okay to do a one-level spinal fusion in 5 hours. Well, for most of people, it might be acceptable, but for people who are borderline unhealthy, have limitation, that is the definition of, or that's practically, can I do it or can I not do it? It comes to efficiency. And we have shown in this study and in the next study, up to BMI of 60, we can do this surgery efficiently, safely, and we have now years of results for that. Patients come from entire United States to us for this. And every additional half an hour on the anesthesia adds 17% to the combined risk of the surgery. So if you can perform a surgery more efficiently, you're going to reduce no matter what the risk associated with that surgery. If you put all the surgeries above 2 hours in one group and all the surgeries below 2 hours in another group, you see that the risks are double in the surgery above 2 hours. Now, why is it important? Number one, it's important because practically every kind of recovery is going to be better with a lower risk. Now, by the way, this study was done on about 400,000 patient meta-analysis. Every patient, just this anesthesia-related risk. And this is prone and supine. These risks are higher in prone patient, by the way. Now, OLLIF is a fantastic surgery, but we understand why OLLIF is not a good option for this high BMI patient. Now, the two procedures that I perform is the OLLIF and prolateral for this group of patients that use the transcambin approach. We talked about all the muscle that we don't have to destroy. And why is it important? When we get to higher BMI, the way it works is that you add another inch of fat, and then the weight goes, it doesn't it doesn't go up a little, it goes up a lot, because you're adding more to the mathematics of it. It works that it's an exponent of 3, meaning that even in the biggest patient of mine, most of the instruments are still long enough to really get the job done. And that is the point. If the instruments are long enough to get the job done, it doesn't really matter if you go through 2 inches of fat or 6 inches of fat. You practically perform the same surgery with one exception. You have to have a good x-rays. I use double C-arm. I manage the tissue. That is the most important thing for this patient, that you manage the tissue. Look at this x-ray. It's hard to interpret this x-ray, but you use just few cents of tape, all of a sudden you have a workable x-ray. These techniques, these are cheap techniques. You don't need $1 million machine to do that. And we have developed this kind of routines that enables you to have good x-rays, but as well, other method to understand, to interpret these x-rays, like everybody these days, when they go and they come out of the residency, they can do only surgery with the navigation machine and with a $1 million robot. That probably one of the worst things that's happening to our spine society, that we are trying to replace the skills with technology rather than add technology as additional tool to our repertoire. So, and it comes that just some very practical tips. Darken the room, reduce the additional noise in the room. Some people are offended because in my room we don't talk socially. We don't listen to music. We only go there to do surgery. As a matter of fact, I have been accused that I'm a mean person because I don't socialize in the OR. but I'm there truly to do one job. And and then you have to start looking at the films. Once you start looking at the films, your brain is made to develop this pattern recognition. Our brain is a pattern recognition machine. And the beauty of this is that what you see here is all you need to do the surgery. Again, it's once you get to it, it becomes routine and it becomes more doable. Like, look at that. In this case, actually the screws are about 1 to 1.5 inch under the skin. Those tower screws that I'm talking about. Okay, but there's an industry solution for that. We just make tower screws a little longer. So these are solvable problem, and I'm talking about that this is a problem that lots of patients struggle with, and here you see the same thing. These are solvable problem. I'm not going to tell you it's easy. It has its own learning curve, but they are doable. And the result is this. The result is that this is the same picture I showed you at the beginning. The mother is crying because after 6 months, sees the son walking for the first time independently. They flew from Cleveland. We do the surgery. Literally, the first night I couldn't extubate the patient because the lung wouldn't recover. The patient was extubated first postoperative day, and in the second postoperative day, patient was discharged from the hospital. On the fourth postoperative day, patient flew back, and I can go on, and I show you lots of patients with the same performance. This is not a singular event here. Now, this is the performance of that. This is that surgery. You have to just repetition. You just learn from continuously you learn. This surgery on this patient with a BMI of 62.5 was 1 hour and 55 minutes with a blood loss of 50 cc. And I go around and I tell to everybody, if you get out of this room and you even get the hint of Abbas is a great surgeon, you've just wasted your time. This, what I want to tell you, what you see here is replicable, is learnable, it's teachable. You just have to go through the process of adopting it. This is the other patient we talked about. So these patients are coming to us. They need help. And again, it's not about that you become cavalier about doing surgery for them. It's about that finally you have a reasonable option for them, okay? So now I'm going to stop here and let you ask question. We have studied, we have published, this patient ambulate with the same frequency. They ambulate literally within 23 hours. What I'm trying to tell you, their performance of this surgery for this group of patients is no different than the performance for somebody has a BMI of 25. And I have 10 years of data to prove that. Now, I'm going to stop here and let you ask questions. There are tons of information there. Connect to me if you have a question. And I'm happy to answer all of those questions. But I'm happy to answer some questions.
Just a great talk, as always. You're very passionate about this. This patient. It's a very difficult patient population. It's just a difficult patient population. I mean, our society has become so morbidly obese, and that's something I'm trying to do something about with all the integrative health stuff that we're doing. But you're right, some of these patients, they come in, they're very stenotic, they're so disabled, they clearly need surgery, and it is true, people in the community don't want to touch this. And I don't blame them, because the complication rates can be higher. You're talking about a surgery that was an hour and the patient can't get extubated. There's a lot of fear out there, but there needs to be some solutions for those patients, because you're right, they do spiral. They gain more weight, and then they have a massive heart attack and die. And so it's very sad. But as you know, there's a lot of pushback on this.
Oh, do I know about that?
I know you know about pushback because I've gone on social to defend you, because I'm like, well,
I know.
Because he's helping people. Like this is problematic. it's just because other people can't tackle some of this. Listen, if you were doing this and people were dying, I mean, we just have to be honest. That's what. So people want to say that, oh, if you operate on these patients, they're going to die. I mean, they don't. They just say that. They're told
Yes.
that in their consultation.
And if they do, we should stop doing that.
You should stop. Absolutely, you should immediately stop doing it.
Yeah.
But the truth is, if it can be done safely, and in your hands, it's a safe surgery, and you're getting a good outcome, this is really what we need to be doing. Now, I think the first goal that we need to do is, I think that we need to get a handle on our obesity crisis in this country. That's
No
first,
kidding.
so that you don't have to operate on these people ever. That's the best thing to do. But if you do have to operate on them, what happens when there's no surgeons that can do this surgery on these patients? What happens? They're randomized to, well, I guess there's not, now with the GLP-1s and stuff, but some of these patients don't, or, they don't respond as well to the GLP-1s for a variety of reasons, or they have other issues, or they're non-compliant. It's complicated, but thank you for taking on this very difficult
Thank you, Stefan.
patient
I
population.
know you and I are in the same kind of boat, that we do things a little different in a more efficient way, and surgeon who needs 7 hours for a one-level fusion, they don't like both of us. Because they think, they need to, the only way they can justify that this is not a joke. There are some surgeons that need for a one-level fusion 5 to 7 hours for a regular surgery, and there is a need for them to justify why they should continue just doing that, and that is the only way they can justify it, is putting people like you and I try to be on the opposite side of where we are, rather than we don't bother with them, we just do what we do for our patient. And the fact is that that these patients do need help, and the goal is never to start with the surgery. As a matter of fact, the goal is for any BMI, surgery is the last resort. If everything else has failed, if phototherapy has failed, if injection has failed, if any kind of other therapy has failed. But I have over hundreds of patient testimonials, and I'm creating an advocacy group for this kind of patient. They want to be heard, because they're fat shamed, they're body shamed. They have been told, that there's nothing to help them, and they literally gather their pills to commit suicide. And that's something that we realistically need to deal with. Thank you.
Yeah, I mean,